So good afternoon everyone. We are live now. Good afternoon one and all. On behalf of Mckenzie Technical team, welcome you to webinar on differential diagnosis for low back pain. We are IAP India YouTube page. So please subscribe to this page to get regular notification of webinars. Now I request Dr. Khushbu to take over.
Thank you, Dr. Trupti. We welcome you all to this webinar on differential diagnosis for low back pain. This is our webinar 7 of the series, and this is the last day, that is day 4 of our webinar. This webinar series is jointly organized by IAPWC Satara District, Maharashtra, in collaboration with Krishna College of Physiotherapy, Karad. I would like to introduce IAPWC, which was started on 30th of May 2018. It functions under the guidance of National Head, Dr. Ruchi Vaishnav, and IAP President Executive, Dr. Sanjeev Jha. IAP Women's Cell works towards conducting public awareness camps, CME, workshops. It aims at bringing together all physiotherapy professionals for sharing knowledge and improving public awareness about physiotherapy. We have 5 zones in India with the heads for each. Dr. Pooja Kamble is the West Zone head. The state team of IAP Women's Cell, Maharashtra, includes the state coordinator as Dr. Suvarna Gandhi, joint coordinator as Dr. Snehal Patel, sub-coordinators as Dr. Uttara Mohan, Dr. Priya Karande, and Dr. Nirali Sangvi. In Maharashtra, IAP Women's Cell has conducted 40+ low-cost activities in various districts and free webinars in the first few months. In the first IAP conference, which was held in Indore in April 2019, Maharashtra State received the award for the best state IAP Women's Cell. I would also like to introduce the district team of Satara, which was established on 31st of January 2019 with a team of 3 members. Dr. Trupti Yadav as the coordinator and assistant professor at Krishna College of Physiotherapy. Myself, Dr. Khushbu Chotai, as sub-coordinator and assistant professor at Krishna College of Physiotherapy, and Dr. Pallavi Kulkarni as the sub-coordinator. I would also like to introduce Krishna Institute of Medical Sciences, deemed to be university, which was established by the visionary founder and chairman and honorable chancellor, late Sri Jayawantrauji Bhosle, our beloved Appa sir. Presently, the university is flourishing under the guidance of Honorable Chancellor, Dr. Suresh Bhosle, Honorable Pro-Chancellor, Dr. Praveen Shingare, Honorable Principal Advisor, Dr. Ved Prakash Mishra, Honorable Vice Chancellor, Dr. Mrs. Neelam Mishra, and respected Registrar, Dr. M.V. Ghorpade. University currently has undergraduate, postgraduate, and super specialty in various disciplines such as medical, dental, physiotherapy, nursing, allied health, and pharmacy. It is the host to 5,000+ students on the environment-friendly campus. It and complex. College of Physiotherapy started initially under MUHS in the year 2002, and in the year 2005-06, the university achieved its deemed status. It currently has undergraduate, postgraduate, and interdisciplinary PhD programs. The college is headed by Dr. G. Varadarajulu from its inception. Krishna College of Physiotherapy is a pioneer institution in Maharashtra with all the facility as per the norms of IAP and Maharashtra State OTPT Council. I would now request Dr. G. Varadarajulu to introduce our speaker, Dr. R. Raja.
Yeah, very good afternoon, one and all. A warm welcome to all the participants for this last lecture of this webinar series jointly conducted by Krishna Institute of Medical Sciences and Satara District Women's Cell of Physiotherapy. So for today's lecture, we have an eminent speaker, resource person from Karnataka by name called Dr. R. Raja, who is a professor and principal at Kempegowda Institute of Physiotherapy, Bangalore. Sir is graduated from, to be in brief, Sir is a meritorious student throughout his career. Meritorious student, meritorious teacher, meritorious professor, meritorious principal. He is a KK Nagar Government College of Physiotherapy student during his UG time. And PG he has done at Savitha Dental College, Savitha Physiotherapy College, Chennai. Awarded in 2018 the PhD in Nitte University, Mangalore. And Sir is served almost in all the categories of physiotherapy profession, starting from lecturer, associate professor, professor, and principal, vice principal. You name any category in our field, he has served in that. Sir has got a tremendous experience in clinical as well as in teaching administration. Sir has published many articles in many Scopus indexed journals. Sir has presented papers in many scientific forums, guided more than 25 MPT students. He has organized, he is very much famous in South India for organizing the conferences. When he was under his leadership in Chennai, he has organized a well-known conference called Stride, Stride 95, Stride 98, Stride 2002. People in Chennai recognized him by the organizing chairman of this particular conferences that he has organized in that particular state. So, Sir has organized workshops, he has attended more than 100 in his credit. He is a UGC State University inspector for various colleges across the country. He is involved in services for more than 14 universities across the country. To name few, starting from Krishna Institute of Medical Sciences deemed university, Tamil Nadu Dr. MGR Medical University, Annamalai University, NTR University, Rajiv Gandhi Streams University, almost all the deemed to be universities in the south and up to the Maharashtra. He is taking part in guiding the board of studies, guiding the academic council. His contribution is enormous in all these 14 universities. So we are really proud and pleasure to have Dr. Raja for this particular guest lecture, which is a very important, which is on a very important topic of differential diagnosis for low back pain. So this topic that has been taught by me, the reason is there are when a patient comes to a department and with a complaint of low back pain, student, especially the undergraduate and the interns and the PGs, they get confused with the diagnosis. What is exactly problem and what is the appropriate treatment that can be decided to this particular patient. So that is why I thought of at least this particular topic will be definitely going to be useful for the undergraduate, interns and the PGs. Of course, for a junior physiotherapist also. So with this brief introduction, I will once again welcome on behalf of the Indian Association of Physiotherapy and Krishna Institute of Medical Sciences deemed to be university to Dr. Raja for delivering his lecture on differential diagnosis for low back pain. Over to you, Dr. Raja, sir. Over to you, Dr. Raja, sir. Dr. Raja, sir. Dr. Raja, sir, you're audible. Dr. Raja, sir.
Thank you, sir. Yeah. Thank you, sir. I'm audible to all?
Yes, sir.
Yes, sir. Hello.
Are you audible?
Sir, I'm audible to you?
Yes,
Yeah,
sir. Yes,
thank
sir.
you. Thank you, sir. Thank you. Yeah. Very good afternoon, one and all. It is my pleasure to be a part of your university webinar series person. First of all, I would like to thank Dr. Mudrajulu sir, the Dean, Krishna Institute of Physiotherapy, and the deemed KIMS, deemed to be an university, Karat, because I am associated with this university, I can say more than a decade. So I would like to thank the university officials and the dean. Next, I would like to extend my warm thanks to the Satara Women's Cell IAP people, Kushbu Madam, and the other two madams. Even I am associated with you people since long time. I'm very proud to be for this honor given by you people. So, in today's lecture, I'm going to speak about the low back pain and its differential diagnosis. Let me share my slide. Before let me start my lecture, I request the audience to mute your phone, because if you unmute, then it will be a lot of echoing, so you cannot hear my voice very clearly. Let me start my lecture. It is differential diagnosis for low back pain. The introduction for the low back pain, right? Most of the Indian population or the population worldwide will experience the low back pain in their life at any one particular point. At particular point in sense where their age ranges between 35 years to 60 years. And if you consider the age, then we have to consider the sex also. If you consider the sex, both male and female patients are highly prone to get the low back pain. Percentage-wise population, out of which the 60% of the general population are affected by low back pain, then 80% of industrial population are also affected, and 20% of the sports personal population are also affected by low back pain. If you consider the patient who is suffering with low back pain, right, where the pain may be there for minimum 2 to 3 months. So any treatment for the low back pain or the treatment by the physiotherapist, we patient where the patient will be all right by 1 or 2 months time duration. That is why in physiotherapy, if you consider, right, the one course of the treatment consisting of 10 days of treatment, and it varies from university to university and hospital to hospital. If you consider the low back pain patients with the physiotherapy treatment along with the medications, the patient will be all right by 2 to 3 months. And also, if you consider the 80% of the population in general all over the globe are suffering with low back pain in the age group between 35 to 60 years. Let me skip to the second slide. Here, I'm going to speak about the anatomy of the disc, right? Disc is the main component where there is the problem. That problem may lead to the low back pain. If you consider the anatomy of the disc contains the water, collagen, and proteoglycans. It works as a shock absorber whenever we do any sort of movement. Whenever we do any sort of movement like sitting, standing, right, where we can say the compression sort of movement and the flexion, the rotatory movement, any sort of the physical activity is allowed by the disc, and the disc is acting as a shock absorber whenever we perform the physical activity. Then the other important point in the disc is it occupies, if you consider the vertebral column of the human body, we have the 33 vertebrae, right? If you consider the vertebral column as a log, in that the 25 to 33% of the space is occupied by the disc in the vertebral column. Next, let me speak about the component of the disc. The disc consists of the nucleus pulposus as the center area, then the annular fibrosis, which is encovering or encircling the nucleus pulposus, and the vertebral end plates. Then let me speak about the pathology of the lumbar vertebra or the disc. If you consider the main pathology which is considered in the lumbar region, or if you consider the cervical region, The main problem is the disc prolapse. How the disc prolapse may happen? The disc prolapse may happen, it is due to protrusion or extrusion of nucleus pulposus through the annular fibrosis. If you consider in that way, which are all the common site for the disc prolapse? If you consider the common site at the lumbar region, it is L4 and L5, and if you consider at cervical region, it is C4 and C5. Why these two regions are very common for the disc prolapse? So these two regions, or if you consider these vertebrae, have more mobility than comparing with the adjacent vertebrae. If you do consider, whenever there is the mobility, whenever there is the maximum movement, there are chances of wear and tear, right? If you take it in that sense, the L4, L5 at lumbar region and C4, C5 at cervical region, plus or minus one vertebra, where there are much of the movement, which induces the wear and tear, there, which in turn leads to the disc prolapse, right? Such a way, the patient is suffering with the disc prolapse. If we consider the prolapse of the disc, which are all the common site of the prolapse we can see or we can say. If you consider in general, most of the population will have the posterior lateral prolapse. That is very, very commonly seen, and there are a lot of literature supporting research literatures are there. Then if you consider out of 40 to 50 percentage, where there will be the lateral prolapse, which can be seen, and very, very rarely, I can say 5 to 10 percentage, where there is the anterior prolapse, which are seen in the disc. Explain about the type of the disc pathology. If you consider the type, the first type, which is called as the self-contained disc lesion. The self-contained disc lesion means there is the disc problem, but there won't be any bursting or there won't be any protrusion, extrusion, right? And there will be increased distal pressure, right? Which is called as the self-contained disc lesion. And the second type, which is called as the disc lesion with nuclear extrusion. If you consider the nuclear extrusion, there will be the increased distal pressure, it is the nucleus pulposus pressure due to the excess movement at L4, L5, or if you consider cervical region, C4 and C5. Because of the repeated motion, the nucleus pulposus, which may burst out and which may makes the way through the annular fibrosis and which protrude out or extrude out, and there are chances of compressing the nerve pathway, right? That is called as the second type of the lesion. Now, let me skip to the fourth slide, where I'm going to speak about the herniated lumbar disc. As we saw in the previous slide, right? The disc, how it can be affected, right? The affected disc, which is called as the herniated disc. So, in this topic, today I'm going to speak about only the low back pain, which is absolutely related to lumbar disc, that is L1 to L5. Right? If we consider the herniated lumbar disc, the herniated nucleus pulposus can be seen, right? So whenever there is the herniated disc, there are chances of the sciatic symptom. As we all well familiar about the sciatic symptom and the sciatic pain, where the patient will be complaining of pain from the back region, starting from the gluteal fold or gluteal region, and it may extend till the toes or till the calf region or till the thigh region or till the knee region. It depends upon the amount of the compression and the sciatic nerve from the root level. For this, what are all the things, the special tests we used to do to check out or to rule out the disc prolapse? The first test what we used to do is the straight leg raising, which is called as the SLR. SLR will guide us towards the disc prolapse. Then the second test, which is called as the Lazarus test, even the Lazarus will guide us towards the disc prolapse. And the third one is the slump test, as we all well familiar how to perform the slump test. The fourth one is the bowstrings test, and the fifth one is the Valsalva, right? Whenever we perform the Valsalva, where we instruct the patient to take the breath hold and hold the breath for the longer time and compressing the nostrils, where the patient is to try to tend to do the expiration where the air should not pass out through nostrils. So what will happen when we perform this maneuver? So there are chances of increased intrathoracic, intrapleural, and intra-abdominal pressure. Through that, there are chances of increasing intraspinal canal pressure. Whenever there are chances of the lesion inside the spinal canal or in the nerve root, right? In that particular case, as a physio, we have to perform the Valsalva maneuver. This Valsalva maneuver will guide us towards the destiny. Next, let me explain about the stages of the disc prolapse. If you consider the first stage of the disc prolapse, which is called as the stage of degeneration. In the stage of degeneration, you can see there won't be any bulging, but there will be increased distal pressure due to excess motion of the above and below vertebrae. Second stage, which is called as the stage of diffusion, where we can see there will be the just a bulge, where we can see the bulging of the nucleus pulposus. This bulging will start compressing the areolar fibrosis. Then the stage 3, which is called as the stage of extrusion. In the stage of extrusion, we can see in the diagram, which is nothing but out but in contact. The central nucleus pulposus is torn off from its position and which is compressing, which is making way through the areolar fibrosis and which is start extruding from its original position. Then the fourth stage, we used to call it as the sequestration stage. We are out, but there is no contact, which is totally out, or 3/4 of the part which is out from its original position and which is start compressing the nerve pathway, where patient used to give complaint of the numbness, or they used to say like the burning pain from the foot or the leg portion. Then the fifth stage, which is called as the stage of fibrosis, right? When the patient reaches the stage 3, 4, and 5, where the patient is directed to the neurologist or neurosurgeon opinion. Along with their opinion, the patient has to be directed for the surgery. But if you consider, according to our experience, we can manage the patient up to stage 1, 2, and 3. But when the stage is 4, where there is no nerve compression, but there is the disc prolapse, in that case, we can maintain the condition. But when it started giving the pressure over the nerve root, where patient is having very severe pain, in that case, patient has to undergo the surgery. Then let me explain about the causes of low back pain. If we consider causes of low back pain, the first cause is acute lumbosacral strain. Let me explain this. Any one or two, please unmute and let me know I'm audible to you all. Any one or two?
Sir, audible.
Yeah, thank you. Now, the causes of low back pain, if you consider the causes of low back pain, the first cause is the acute lumbosacral strain. Then the second cause is unstable lumbosacral ligament. If we consider acute lumbosacral strain, it is very commonly seen in case of the person who sit and work in front of computer for longer duration, or the person who does the repeated lumbar flexion motion. If we consider the second type, the cause, the unstable lumbosacral ligament, which is very commonly seen in elderly individual or who does the vibratory tool work or who does the longer standing or prolonged sitting job. Then the third cause, which is called as the back muscle weakness. Back muscle weakness, again, it is due to prolonged standing, prolonged sitting, or even I can say the obese individual back muscles are weakened. Then the fourth one is IVDP, what we have seen in the previous slide, I will explain. Then the fifth one is spinal stenosis. The spinal stenosis it is not the acquired condition, it is the condition where the spinal canal space is reduced, right? That may induces the low back pain. Then the next one is the osteoarthritis of the spine. One, the unequal leg length, which is very commonly seen in any post-fracture conditions, exclusively the femoral component fracture. Apart from that, any fracture at the pelvic region where there are chances of limb length discrepancy. Due to limb length discrepancy, there are chances of low back pain. Because of the limb length discrepancy, the biomechanics of the spine or the vertebral column may change. Whenever there are chances of changing the biomechanics of the vertebral column, there are chances of more strain over the back, which in turn leads to the disc prolapse, which in turn leads to very severe pain at their low back. Then the next class, which is called as the pelvic disorders, there are plenty. Apart from that, the retroperitoneal tumor, abdominal aneurysm, and psychosomatic problems, or even these problems which may induce the low back pain. Then last, the obesity and stress also induces back pain. Let me move to the next slide. What are all the common clinical features we can see or we can say on the low back pain patients? The first feature is severe low back pain, right? Then the second one is it radiates down to the thigh, calf, and posterior side, right? The extension of the radiating pain depends on the quantum of the compression of the nerve pathway at the higher level, at the lumbar vertebral level. Then the third point is the pain increases during cough, sneeze, and laugh. As I already explained in the Valsalva maneuver, you do consider whenever we cough, sneeze, and laugh, there are chances of increased intra-abdominal, intrathoracic pressure, which in turn pushes the pressure to the spinal canal. So through that, the patient complains of pain. Then the fourth point is the pain increased at the night time. Fifth one is Valsalva maneuver, already I've explained you. Sixth one, pain increased during flexion of spine. Whenever we do the frequent flexion of the spine, there are chances of increasing the quantum of the pain as per our scale. Then the next point is the prolonged sitting, increased pain, then standing, then severe tenderness and muscle spasm in erector spinal muscle, which is considered as the pillar for the back. Then the next one is the tenderness on spine. Wherever we feel the spinous processes, there will be the tenderness over the spine. Then the muscle weakness and decreased muscle endurance can be seen, and decreased deep tendon reflex and the sensation can be seen in case of the low back pain patients. Next, let me speak about the causes of the pain. The first cause is the degenerative cause. The degenerative cause is very, very commonly seen in most of the individual in the middle age of Indian population, and even you do consider worldwide population, where we can say the degenerative joint disease, which is considered as the spondylosis, right? And the spondylitis, it is due to the inflammation. Then the second cause, the main cause is the instability. Right? Whenever there is the fracture or whenever there is the fracture at pars interarticularis, where we can see the dog-eared sign in the X-ray, right? Where we can say the spondylolisthesis, right? In this case, there will be a very severe pain. Then the third cause for the pain is the organic, which is due to the tumor or the infection. And the fourth one is the nerve compression or irritation, right? It is due to the root compression, right? The root compression, it is due to the disc prolapse or it is due to the entrapment neuropathy. If you consider the disc prolapse, though my topic is very particularly to the lumbar spine, so let me consider only the disc prolapse inducing the root compression. Then the last point, which is considered as rule out psychogenic cause, right? Rule out psychogenic cause where it is very rarely seen, and where these patients are even they are directed to physiotherapy, where we have to give according to their psychological depression or the anxiety level, we have to plan our treatment. Then, what is the referred pain and how this referred pain, which mimics like the low back pain? If you consider the abdominal cavity, right, in the abdominal cavity, the gastritis or the peptic ulcer, right? Even these patients, they used to give a complaint like they have very severe back pain. So the patient has to be ruled out by way of directing the patient to the medical practitioner. Then the second thing is pancreatitis. Even the pancreatitis or the cholecystitis patient also complains of pain at their back where the lesion is in the visceral organ. So the patient will be directed for the medical assessment. Then the second individual, right, those who are having the renal calculi or the urinary tract infection individual also gives complaint of pain at their back. Even these individuals should be directed for the ultrasound by the way of directing the patient to the physician. And the next, the pelvic cavity region, referred pain. Under that, the first condition, which is called as the ovarian cyst and area. Even these patients, they used to say they have very severe back pain. So we should not get misled or misguided by the way of doing our assessment. So whenever you do our maximum or the proper physiotherapy assessment, exclusively the orthopedic and neurological assessment of the back and the now, so we can come to the conclusion and we can direct the patient towards the individual specialty people to do the real assessment on the patient. Then the next one is the aorta, right? If we consider the aortic aneurysm, also induces pain at their back. So the patient will be directed to the cardiologist for the further evaluation. So the referred pain and the other important terminology which is called as the radiating pain. If we consider the low back pain patients, few patients they will have referred pain whenever they don't have any nerve involvement, whereas they will complain of radiating pain whenever there is the absolute disc prolapse, there is the prolapse disc which is compressing the nerve pathway. So, as a physio or the physiotherapist, we have to see whether the patient is having the visceral organ referred pain or the patient is having the absolute disc prolapse referred pain. So, we should be familiar doing our assessment. Based on our assessment, either we can continue with our treatment or if assessment fails, where we have to direct the patient towards the individual specialty people for further evaluation of the patient. Then the next type of the pain, which is called as the mechanical pain. If we consider the mechanical pain, the first one is the muscular strain, which is called as the pain, right? The mechanical low back pain, where we can say the muscular, it is induced due to the muscular strain. Then the second type of pain, which is called as the ligament strain-induced mechanical pain. Then the third one is the facet joint arthritis-induced mechanical pain. And the fourth one is the discogenic pain-induced mechanical pain. And the fifth one is instability. Already we explained you the spondylolisthesis. And the other condition which is called as the spondylolysis. Now, let us get into the diagnostic procedure, how we can do the diagnosis for the low back pain patients. Here, you can see I've made the individual diagram of individual diagnostic procedure. If you consider the diagnostic procedure, the first diagnostic procedure is the plain X-ray. I think anyone, you please unmute and let me know. You can see the cursor where I'm moving. Anyone? Anyone in the audience?
Yes, sir.
So now you can see the plain X-ray. The first diagnostic procedure is the simple plain X-ray. You can see the plain X-ray of lumbar vertebra, right? Where the simple plain X-ray of anteroposterior view or the lateral view. Lateral view I have not put here because there is no space. I've included only the anteroposterior view, right? Then the next one is the MRI, where we can see the second picture, where there is the MRI, where we can see the spine as well as we can see the disc, the white color portion which is called as the disc, and here we can see the spinal cord and the spinous processes, right? And we can see the space, right, where the dotted line which denotes how much the space reduction which is seen in between the discs. For that, they used to do the MRI, and they used to do MRI to see the amount of the prolapse. Then the third diagram, which is called as the CT, right? The computer tomography, where we can see the lumbar vertebrae and we can see the spinous processes and the other soft structure. Then the last diagnostic procedure, the recent one, which is called as the discography. You can see the discography where they just insert the needle and they'll just see how much disc problem which has happened, right? Whether the discal problem is in the center or in the periphery, right? They will see through the discography. Then the next the next slide, which speaks about the special test for the low back pain patients. Here, we included the diagrammatic representation also, along with the individual test. The first test, which is called as the straight leg raising. Straight leg raising, which starts from 0 degree to 90 degree, but no need to take up to 90 degrees. But if you consider the most of the Indian population, they will be having the hamstring muscle tightness. So you cannot go up to 90 degrees, you can go up to 45 or 60 degrees, or at the maximum you can go up to 75 degrees if hamstring permits you to go, right? This guides you about the nerve tension, this guides you about the disc prolapse, this guides you about if there is any chance of SI joint strain. Then the second test, which is called as the lassitude test. Here you can see the diagrammatic representation of the lassitude test, right, which is called as the lassitude sign or the regard sign, right, where the operator is doing the rotation and they are palpating the nerve pathway and they are doing the minimal dorsiflexion, where they are feeling the pain or not. When the operator does such a movement, there will be a chance of the nerve tension. This increased nerve tension, which induces the pain over the course of the nerve or the course of the nerve or the muscle supplied by the nerve. Then the third physical test, which is called as the cross SLR, where we can see the cross SLR in the cross straight leg raise. Even this will guide us towards the right, the nerve tension. Then the fourth test, which is called as the Fibrosis test, which is very commonly done by all physios, even the interns and PGs, where it will guide us towards the SI joint strain as well as the nerve tension. Right? Let me speak about the other special tests. The next test, which is called as the bowstring. Most of the physios, we are not doing this test, even this test, which will show you or guide us towards the nerve tension, as well as we can feel the nerve and way of doing the bowstring. Then the next very, very important test is done by most of the physio, which is called as the slump test. It contains the 3-segment or 3-component test. The first component, where the physio is directing the patient to perform the neck flexion, followed to that the thoracic flexion, followed to that the extension of the lower leg, the knee joint and the dorsiflexion of the foot. When we perform this test, it induces the tension over the nerve or the course of the nerve where patient feels or the patient gives complaint of very severe pain over the nerve course, right? That shows the positive sign. Then the next test, which is called as the femoral nerve stretch test, where the person is performing. I've included the photographic representation, where we can see whether the femoral nerve also included or the femoral nerve also intact, right, along with the sciatic nerve, right, to rule out that we are doing this test. Then the test which we used to perform is the compression and the distraction test, right? Even this test guides us towards the destiny about the patient problem. Then, now let me enter into the differential diagnosis of the lumbar spine and the conditions. The first condition, which is called as the spondylosis. There is the diagrammatic representation of the spondylosis, right, where we can see the pain in hyperextension on lumbar spine. Whenever the patient performs the hyperextension, there will be very severe pain and there will be the hamstring tightness with SLR positive, right? Where we can see the disc and the vertebra, the fracture at the pars interarticularis we can see, right? Exclusively the posterior part of the vertebra, right? This can be seen in case of spondylolysis. Then the second condition, which is called as the spondylolisthesis, how we can see the spondylolisthesis, we can see the X-ray finding, right, where the L5, which is moved forward on the S1. Here you can see the L5 is moved off of its size. I can say 50% of L5 is moved, right, where we can see as an operator, if we palpate on the back, right, we can see the step of sign, right, we can see, and we can see there will be the absolute 50% of the movement of the vertebra over the other vertebra, which induces the compression of the nerve pathway, right? So it induces the sensory deficit. Then this type of the spondylolisthesis are very commonly seen on individuals who fall from height, right? Mainly it is exclusively seen on the patient who climb the palm tree, right? Or the patient who climb on the coconut tree, right? Or the patient who does the diving on the swimming pool, right? And lands on their buttock, right? On that case, there are chances of this. Apart from this, is the force is too huge or the height is too heavy, right? More than 10 feet, 15 feet. In that case, there are chances of the bursting of vertebra or the vertebral fracture may occur. If we consider the second type of the condition, which is called as the spondylolisthesis, right, where here in this diagram, I've taken the 50% of the movement, which is nothing but the grade 2 spondylolisthesis. Up to this grade is managed by us, physiotherapist. Once the condition is switched over to grade 3 or that case, the patient is directed for the surgical procedure, right? And here, the X-ray finding also guide us towards the spondylolisthesis, where we can see the spotty dog ear sign, which is nothing but already I showed you here the fracture of pars interarticularis on the spondylolysis diagram. Then the third condition on the differential diagnosis, which is called as the lumbar spondylosis, which is very commonly treated by the physio. Right here, you can see the third condition where in the third condition, we can see the decreased range of motion, and we can see the pain on the movement. Why there is the decreased range of motion? It is due to the degenerative changes over the spine and the intervertebral disc. Then the next condition, which comes under the differential diagnosis, is the spinal stenosis, where we can see the picture where there will be the loss of lordosis, pain relieved by forward bending and sitting and lying. Alternate or abnormal SLR can be seen on this case. Passive extension reproduce the symptom. There will be more pain whenever we do the passive extension, and there will be the intermittent claudication, the leg pain, numbness increased while walking and while standing also on few cases. Then the next condition, which is called as the Pars disease, it is nothing but the TB bone of the lumbar vertebra, right? And this is seen on the diagnosed by the physician as a tuberculosis TB bone. So those individuals are very prone. You can see the diagrammatic representation of the TB bone or the TB vertebra. And here we can see the intermittent claudication, cold abscess, and the stiff spine and are very, very commonly seen on this case. On the next slide, the spinal tumor. Here I have included the diagrammatic representation of the spinal tumor. You can see the tumor, the length of the tumor, right, which is seen on the MRI, right? And you can see there will be what are the features of the spinal tumor. If you consider the first feature is the nocturnal pain and sleep disturbance, Sleep disturbance mainly at the night time can be seen due to the internal pathology. Then there will be the continuous pain, and there will be elevated ESR, erythrocyte sedimentation rate, and tuberculosis. There are chances of possible anemia and the bony erosion also can be seen. Then the next condition under differential diagnosis is the lumbar fracture. Right. Already I have explained you about the diving on the swimming pool from very high, or the person who climbed the palm tree or the coconut tree, right, fall from the height more than 10 feet or 20 feet, landing on their buttock, right, where there are chances of fracture of the lumbar vertebra. Right, you can see the fracture of the lumbar vertebra, right? So, which induces the paraplegia, right? So, the type of the paraplegia, or it is depends on either the UMN or LMN type of the lesion. It depends on the amount of the spinal cord and the spinal nerves which are involved, right? Then the plain X-ray, which will guide us about the fracture vertebra. But to know the spinal cord problem, how much spinal cord is involved, how much spinal nerves are affected, we have to direct the patient for MRI for final diagnosis. Then the other condition which is very commonly is the piriformis syndrome, right? As a physio, we are seeing on everyday webinar, right? Piriformis syndrome has its vital role because most of the physios are treating piriformis syndrome as a disc prolapse, right? So here we can see the piriformis syndrome, the diagrammatic representation, and here you can see the pain which is there at the gluteal region and back of the thigh, right, which resembles like the sciatica. And here there is no lumbar pain. There won't be any pain at the lumbar region, exclusively in piriformis syndrome. Then whenever we does the piriformis muscle stretch, right, there will be a very severe pain complained by the patient. So through that, we can make the differential diagnosis of piriformis syndrome from intervertebral disc prolapse. Then the other differential diagnostic conditions, which resembles like the low back pain or the SI joint lesion, right, where we can see the irregularity of SI joint or the spinosis, right. Apart from sclerosis, right, there will be a very severe pain which resembles like the low back pain, right, and these patients are diagnosed by the Faber's test. Here the Faber's test will become positive, and exclusively the compression and distraction test also will be positive, mainly in case of SI joint lesion. Then here the patient complains of pain at the LS region, some lumbosacral region, pain at the buttock, groin, and the thigh region. Then the next condition under the differential diagnosis is the low back sprain. If you consider the low back sprain, it is nothing but the mechanical low back pain, right, where we can see the tenderness over the paraspinous muscle. Then the symptoms on flexion of 70 degrees, right, there will be a very severe pain. Patient cannot be able to do beyond that, and there won't be any neurological symptoms on low back sprain cases. At last, if we consider hip pathology, also resembles like the low back pain, where there will be the referred pain. There won't be any radiating pain, and even this condition can be differentiated by the way of doing the Faber's test. And here, in this case, the SLR will become negative, whereas the SLR will become positive in case of intervertebral disc prolapse condition. And there is no lumbar spine pain in hip pathology condition. These are all the way how we can make the differential diagnosis on different condition from the disc prolapse case. Then, how we can manage the low back pain patient? If we consider the management is categorized into three main directions. The first one is the rest, the second one is the reduction, and the third one is the removal. If we consider the rest, what all the sub-content or the what are all the points we have to consider under the rest? The first and the best treatment for the low back pain patient is the bed rest, right? Always you should direct the patient to go for the bed rest minimum 1 or 2 weeks whenever they have very severe pain. Then the second treatment which is there on low back pain during the bed rest time is the bedside traction, right? The bedside traction, which is considered as the mechanical traction, either you can give the bedside mechanical traction. Instead of that, you can give the skin traction also to reduce the pain. Then the third point under the rest period is NSAIDs. NSAIDs are prescribed by the orthopedic surgeons or the physician. Along with NSAIDs, if there is any pathology, the antibiotics and muscle relaxants are prescribed. Then the fourth point under the rest is resting or giving rest or stabilizing the spine in a proper position is done by the spinal cord, right? Apart from that, under the rest, the last important point is reduce activity. Reduce activity in sense here, I mean to say the normal activity of daily living, right? Even sitting, standing, walking, right? Or turning towards any other side, or tilting, anything, any activity should be reduced, right? So that will give the absolute rest to the spine or the spinal column. This will help to reduce the pain in case of low back pain patients. Then the second point under this heading is the reduction. What is the meaning of reduction? Reduction means reducing the pain as well as reducing the individual person's activity, right? If you consider the first point under reduction is the continuous bed rest, right? Again, what we have discussed in the previous slide. Then the second point is the traction for minimum 2 weeks. It is advisable, right? And whenever they offer the traction, they will see the traction can be given as either mechanical or the skin traction. The traction can be given bed in a neutral position or the leg end of the bed is elevated position, right? Whenever the leg end of the bed is elevated, then the weight offered to the traction force should not exceed more than 2 to 3 kilograms. Whereas if the leg end is kept in a flattened position, where we can increase the weight up to 6 to 8 kilograms. It depends on the patient body weight. Then at last, the epidural injections done by the orthopedic surgeon. Then the third point under the treatment, which is called as removal, indication for disc removal. When the disc can be removed by the orthopedic surgeon. If you consider whenever there is the cardia lesion, where the lesion is compressing the spinal canal or the spinal nerves, right? In that case, the disc can be removed. And if there is any neurological deficit, right? When there will be the deficit, there are chances of the extruded disc, which is coupled, right? In that case, where patient cannot tolerate the pain, where there will be the very severe burning pain over the foot and the leg region, right? In that case, the patient is ready for the surgery because already the alarming sign of the burning as well as the numbness would have been started on their feet. Then the third point, which is called as the persistent pain and signs of nerve tension. And the fourth point is very severe disc prolapse. In that case, the patient is directed for the disc removal. Then the next point for the disc removal, if you consider the disc removal, which are all the other types of surgeries they do, right? So for that, the first type of surgery for the low back pain patient are considered as the laminectomy. If you consider the first diagram, right, where they've shown the removal of the lamina, the part of the lamina, which is called as the partial, and remove the entire whole part of the lamina, which is called as the complete laminectomy or the total laminectomy, right? So here, the one side of lamina and ligamentum flavum are removed, which releases the nerve tension, right? That is for that purpose, the surgeon is performing the laminectomy. Then the second type of surgery, which is called as the discectomy, discectomy can be partial or total. You can see the diagram, right? So it depends on the quantum of the exclusion or the quantum of the sequestration, right? Based on that, they do the partial or the total discectomy. The third type of this is there in the market, in today's market, in surgeons' market, it is very, very commonly seen, right? Because most of the patients, they don't want much of blood loss, right, during surgery. That microdiscectomy, right? This microdiscectomy can be done through either the pinhole or the metanole or the keyhole surgery, right? They are doing this, right? They are doing with the posterior approach, right? It is done by the scope to remove the herniated disc. Here you can see the part of the disc which got herniated and which start compressing the nerve pathway is removed by the surgeon, right? Through the microdiscectomy procedure. Then the other surgical procedure, which is called as the percutaneous discectomy, the percutaneous discectomy, right, which is the recent advanced surgery where they are doing of the disc, the extruded disc. They're just aspirating through the needle, right? Then the open surgery, which is you can see the spine which are fused and the disc which are removed. You can see the X-ray film, right, which is denoting or showing the screws and the stabilizing rod over the disc. Then the last surgery, which is very uncommonly done, right, on these patients, or the decompression, right? Nowadays, whereas if you go 1 or 2 decades before, these two surgeries were very, very familiar, the spinal fusion and the decompression. But nowadays, due to the advancement in the science, right, they are going for the percutaneous discectomy or the microdiscectomy surgeries. Now, let me get into the physiotherapy treatment, right? What is the physiotherapy treatment? What all the physiotherapy treatment we can do, right? If we consider the physiotherapy treatment, which is considered as the conservative treatment for the low back pain patients, the first physiotherapy treatment, which is called as the electrotherapy, then the next one is the exercise therapy, third one is the manual therapy, fourth one is the massage therapy, fifth one is myofascial release, and the sixth one is the dry needle therapy or the dry needle technique. If you consider the myofascial release, right, these two are the advanced treatment which is there in the physiotherapy market today. That is why I have included the diagrammatic representation here, right? The myofascial release to the erector spinae muscle, right, and the entire back muscle can be done in this direction. And you can see the dry needle technique where it is banned in few countries in the world, but still it is there in the market where we can see the needles over the erector spinae muscle and they do the dry needling to reduce the pain. Now let us get into the normal electrotherapy treatment which we used to give in our department, right, which is called as the intermittent and continuous pelvic traction, right, in which case we can give intermittent, in which case we can give the continuous traction. If you consider the intermittent, where there won't be much radiating pain, right, in that case, there is the back pain, but there is no much radiating pain. In that case, we give the intermittent pelvic traction, whereas the continuous pelvic traction can be given with the help of with the help of the electronic or the mechanical or the bedside traction, right? So this can be given exclusively whenever there is the maximal disc protrusion or the extruded case where the protruded or extruded disc which is compressing the nerve pathway and the patient is complaining of the radiating pain. Then the next treatment modality, which is very commonly given, which are considered as the interferential therapy, right? Interferential therapy can be given as a 2-electrode, 4-electrode, and 4-electrode vector. What is the meaning of this? Either to 2-electrode or 4-electrode. If you consider 4-electrode, in the 4-electrode 45 is there and 4-electrode 90 is there. What is the meaning of this? 4-electrode 90, right? To cover the maximum region, 4 electrode 45 to cover the smaller region. And at last, the last point, which is considered as the 4 electrode vector. What is the meaning of this? The 4 electrode vector, where the physiotherapist is giving our responsibility to the machine to take care of the patient, where the physiotherapist could not find or locate the pain. Right? In that case, the machine will locate the pain and it will treat the patient problem. Then the third treatment technique which are given for back pain, which is considered as the continuous or pulse ultrasound therapy, right? The pulse ultrasound therapy for the acute stage of the condition, where we can give 0.5 to 0.8 watts per centimeter square for acute, 0.8 to 1.2 watts per centimeter square for subacute, and 1.5 to 2 watts per centimeter square for chronic patients. If we consider the acute patient will be given 3 to 4 minutes of treatment. Subacute is given 4 to 6 minutes, and chronic patients are given 6 to 8 minutes of treatment with direct contact technique. Then the continuous mode of ultrasound will be given only for the chronic patients, right, who are suffering for a longer duration. Then the next treatment for the back pain, which is considered as the diathermy, which is very commonly given by all physios. Then the microwave diathermy, these two modalities which comes under the high frequency along with the ultrasound therapy treatment. Then very rarely we are giving the moist state pack and the back. Then recent trend for treating the back pain patient, which is considered as the cupping therapy. You can see the cupping therapy, right, where the cups are fixed, where there will be the vacuum or induced, right, which gives the continuous pull over the muscle, which in turn increases the blood flow to the region, and which in turn relaxes the muscle. Through that, the patient is getting pain relief. Then, what the next treatment protocol for the back pain patient is the exercise therapy, right? Which are all the muscles we are mainly concentrating for giving exercise therapy are the erector spinae muscle and the external oblique muscle, then the multifidus muscle, the transverse abdominis, then the core muscles, right, anterior and posterior, right? And I've shown the catechal exercises where there will be the absolute pelvic movement, and I've shown as the king cobra pusher exercises, Savasana, right? So what we are doing by way of giving exercises, right? By way of giving exercises, we are strengthening all these muscles, right? And we are inducing the more strength to the core muscles, right? Which induces more stability to the cerebral column, right? Through that, the patient will be free from the pain. So for that, what are all the exercises we can do? The first exercise, which is called as the erector spinae muscle exercise, right? Which is nothing, the Mckenzie exercises, then you can see extension exercises already explained you. Then the cat and camel exercises to maintain the core muscle again. Then the king cobra posture exercises to induce to strengthen the erector spinae muscle. Then what is the advancement for treating the back pain patient? If you consider the advanced treatment, right? We are going towards the manual therapy. We are not depending or we are not using much of the machineries. Whereas if you go back 3 decades, right, when we were students, those days there are not much of manual therapy, right, where which was used by our teachers and even by us, right. Those days we were totally depending on the machineries. But nowadays, since these 2 decades, the manual therapy has become very familiar and it gives a good result on the back pain patients, right? And here, the first technique which is used to reduce the back pain is the Maitland mobilization, The grades according to the severity of the patient should be given, and none of the manual therapy should be given in any post-operative conditions. You should not give. Then the second technique, which is called as the CDAX technique, where they used to do the minimal stretch and they do the mobilization of the spine. And the third technique, which is called as the Mckenzie technique, where they instruct the patient to do the forward bending in the extension, then knee to the chest, then the tilting of the spine, then the cobra position, right? To strengthen the erector spinae muscle. Then the fourth technique, which is called as the Mulligan technique, they perform the technique of the Mulligan belt, right? By the way of reaching the other region, they strengthen the back muscle. Such a way they do the therapy. Then the third treatment technique for the patient, which is called as the massage manipulation, right? For doing the massage manipulation, the patient position and the physiotherapist position is very, very important. Right? For doing back massage, the patient position is patient should lie on their abdomen. So they've got the prone lying, then the operator position, the physiotherapist position is either the stride standing or the walk standing position. If we consider what all the technique we have to give for giving the back massage, the first one is the stroking. Stroking is followed by the effleurage. Stroking can be given either the firm stroking or the light stroking, right, to trigger or to stimulate the sensory nerve endings as well as to trigger the muscle, right? Then the next technique, which is called as the palmar kneading technique. Palmar kneading technique is given to the whole back, followed by the effleurage. Then the hacking technique. Hacking technique can be given to the muscular part, right? The bony part should be avoided. We should not perform. So it is considered as the powerful technique. It induces directly the nerve endings, followed by effleurage. Then the friction technique can be given in between the spine or the spinous processes, right, to maintain the spine mobility, right, and this friction which will help to break the adhesions in between the vertebral column. Then, what all the assistive devices we can give, right? If we consider the assistive devices for the low back pain patient, the first assistive device is LS belt, where the LS belt, which is starting from T10 and which is extending till the S1 or till the tailbone, right? And this is called as the lumbar corset. To show the extension of the belt, I've taken this diagram. Then the third technique, which is there in the market, this is making a big business today, the kinesio tape, right? The kinesio taping technique, KT tape. KT tape can be given in the horizontal as well as the vertical direction, right? Where they are concentrating the erector spinal muscle and they are concentrating the effector vertebrae. This taping can be given, or this taping can be renewed once in 5 days or once in 3 days. Then the last and important thing, right, which we used to advise to the patient is the ergonomics, right? We are all suffering with the back pain. The first thing is the workstation, how the workstation should be, right? The workstation where the person who is sitting, right, where they should view the laptop or where they view the computer with 10 to 30 degrees, and while viewing, the person should maintain at least 45 to 70 centimeter distance. And you consider their chair, the chair should have minimum 35 to 50 centimeter, and you can see whenever they are sitting on the chair, right, their back is absolutely supported, it is supported. You can see the arm is supported on the armrest, and both the thighs are supported, and you can see at last the foot is supported on the ground, on the floor. Important whenever the person works on the computer, right? This is exclusively this ergonomic advice should be professional, or nowadays most of the profession are much computer oriented. So the person who is doing the computer job more than 5 or 6 hours in a day should follow this protocol to come out of the back pain. Then you consider the second diagram or the second picture, which shows the standing position, right? In the standing position, how the line alignment of the line from the vertex, right, till the ground or the floor, till the lateral malleus, how the line is passing, that you should see, and how the upper limb which is supporting on the platform. That is very, very important. Then rest during the work. What is the meaning of rest during the work? They cannot stop working. They have to work, and during work, by every half an hour or 1 hour, they should make at least 10 yards or 100 yards walk. Right? That relaxes their spine. Then at last, if we consider the back exercises can be either the Mckenzie extension exercises, cat and camel exercises, or the cobra push-up exercise, or we can say the Williams flexion exercises. Any exercises can be given to the lumbar stability as well as the lumbar mobility. So at last, what exercises can I do to strengthen my back? Right, you can see here the patient is performing the flexion of the knee, where the knee joint or the thigh, anterior aspect of the thigh, which is touching the chest region, and you can see it is unilateral, and here the patient is doing bilateral. Then the patient is performing the pelvic bridging, and the patient is performing the minimal, rotational, or the torsional move to strengthen the muscles. Now, at last, this is about my presentation for the differential diagnosis. Right now, any question? Thank you one and all for your patient listening. Any question from your side?
Thank you very much, sir, for your lucid presentation. Very much explanatory, more in detail. And we are happy to attend your lecture, and hope the stakeholders who are attending this lecture really benefited out of this. And thank you very much, sir. Now we'll ask Dr. Amrut to take up the questionnaire section.
Yes, sir. Thank you, sir. So we have few questions in our chat box. So I'll be going through few of them. The first one is a diagnostic importance of history of present illness for diagnosing low back pain.
Repeat it, madam.
What is the diagnostic importance of history of present illness for diagnosing low back pain?
We are concentrating on the low back pain. It's very, very important. That is what I've shown the differential diagnosis slides with the picture. If they go through that again, they will understand of the individual diagnostic procedure, right? In that, particularly, physiotherapists should not be misguided by the visceral organ pain, which resembles like low back pain. If you consider the renal calculi patient, if you consider the other visceral organ, for example, even the aortic aneurysm patient, right? We should not treat them as a low back pain patient. So immediately the patient should be given attention, and patient should be directed towards the specialized medicine.
Okay, thank you, sir. How to diagnose spinal tumors clinically is our second question.
Yeah, spinal tumors clinically can be diagnosed with the help of Valsalva maneuver itself. While explaining the Valsalva maneuver, already we explained to people, right? Whenever we does the Valsalva maneuver, this is exclusive test to check if there is any visceral, if there is any internal growth in this spinal canal, right? So according to that, we can say there will be the numbness to that particular myotome and dermatome, and there will be the tingling sensation. Through that, we can conclude there is the level at that particular level, there are chances of some growth inside. Apart from this Valsalva maneuver, we can direct the patient to go for the CT or MRI to rule out the absolute extension, the growth of the tumor inside.
Okay, thank you, sir. And one of the last question is stiffness at L4, L5 and posterior superior iliac spine. Apart from doing strengthening exercises of core and back muscles, is it related with vitamin D and calcium deficiency?
So nowadays it has become a very good business by the orthopedic surgeon, right? But if you consider the aging, right, made exclusively in female, right, who attain menopause, right, who is having the lot of hormonal disturbance, or the female who is consuming years together of thyronol more than 100 milligram, right? In that case, there are chances of vitamin D deficiency, but in general, it is not due to vitamin D deficiency because we are living in India, right? It is the hot country. Whereas if you consider abroad, in foreign countries, right, mainly the Western countries, the climate is too cold, so there are chances of vitamin D deficiency there. But in Indian population nowadays, due to the what to say, the upgradation of the software industry, right? The software individuals or the professionals are sitting inside the air-conditioned room for hours together in a day. I can say 10 hours, 15 days in a day. They are not exposing their body into the sunlight. So in that case, there are chances of vitamin D deficiency, which is inducing the pain. But in general, if you do the proper assessment, we can conclude with the help of our physical test itself. No need of CT or MRI.
Okay. Thank you, sir. Thank you
Yeah,
so
ma'am.
much.
Yeah.
Thank you so much, sir. And thank you, Dr.
Thank you, madam.
Amar. We are very grateful to sir for this wonderful presentation and for the beautiful question answer session as well. At this gesture, I would also like to express my gratitude for the support and help from Dr. Suvarna Ganveer Madam, who is Maharashtra State Coordinator of Indian Association of Physiotherapists. Madam was to be here with us and she wanted to share her views and express her gratitude, but because of some emergency, she's not able to join with us, and I shall read it out on her behalf what she wanted to express. Good afternoon, all. The webinar series organized by Krishna Institute of Medical Sciences and IAP Women's Health was an academic feast for the learners. I, as a state coordinator, wholeheartedly express my gratitude towards Dr. G. Varadarajulu, Dean, Krishna College of Physiotherapy, for taking this initiative and getting associated with IAP Women's Health Maharashtra. Looking forward for more such quality work in association with Krishna Institute of Medical Sciences and College of Physiotherapy. Thank you all, the speakers, for sharing their knowledge and sparing time for the noble cause. This is what Madam wanted to express. Thank you so much, Madam, for your valuable time and your gratitude towards us. I would now request Dr. G. Varadarajulu, sir, to express and deliver the vote of thanks.
Once again, very good evening, one and all. This webinar series is one of the historic event in the history of Maharashtra and Krishna Institute of Medical Sciences deemed university. We have started this webinar series on 30th June 2020 on 1st, 2nd, 3rd of July with the 7 lectures by eminent resource persons across the country. So, the highlights of this particular webinar, almost all the resource persons are heads of the institutions and directors of the respective centers and the people who are having more than 25 years, 20 years of the services in the respective discipline. So we are very happy and we should be, I will be grateful to them for contributing their knowledge in this particular platform. I once again thanks Dr. Sanjeev Kumar sir, Dr. P. Kamalnathan sir, Dr. Snehal Deshpande madam, Dr. Signa Mehta madam, Dr. Rakesh Kumar Sinha, Dr. Saumi Sinha, Dr. Raja sir for their valuable contribution for the successful completion of this webinar series. My main intention is to bring all of you, those who are really pioneers in the field, to come on one platform and deliver a lecture to the people who are in need of this kind of a knowledge. I wholeheartedly thank all the resource persons who are heartily involved in this. The next thing is my sincere gratitude to the Indian Association of Physiotherapy, who are really supported us in the venture. The Central CEC members, our own President, Dr. Sanjeev Jha, Dr. Annamalai sir, Dr. Reddy sir, and the Satara district women's cell, especially Maharashtra women's cell. Dr. Suvarna Ganvir madam, Snehal Patel madam, Uttara Mohan, Priya Karande madam, Nirali Sanvi, Ruchi Varshini madam, national aid, Pooja Kamble madam, again a journal head. So all these people are togetherly came and they joined with my notion this kind of webinar. We whole lot, last but not least, my own team, who is, though we belongs to Satara district, people, Dr. Kruti Yadav, Dr. Kushbu Bhatia, Pallavi madam, with us, they have helped in many aspects. It is my duty to say my thanks to them. Once again, the technical team of the IAP, technical team of Krishna Institute of Medical Sciences, Deemed University, who are really helped in this venture. Last but not least, all my staff who have taken the responsibility of each and every speaker and deliver and had a very good contact. In fact, some of the resource persons are very happy with you all. The way you discuss with them, the way you express your views, they were happy. I was really felt very happy. So thanks each and every one of you who are there who are witnessing the success of this webinar series. Thank you all once again. Thank you very much.
Thank you, sir. Thanks, madam. Thank you, Satara Women's Cell IAP. Thank you.
Thank you so much, all the participants, for being with us for all these 7 webinars. We end our webinar and our webinar series. Thank you.